my seat then.
Okay. Greetings, everybody. If you could take a seat, we're ready to start. It's a little, we're running a little late and a few more people may come, but I think we'll start as a courtesy to everybody who's here. Is this working? I have to be really close to it. Okay. We're going to start. We're starting a little late and there's still some people who may come, but I think we'll start as a courtesy to the people who are here so that you can be done. I just want to introduce Corinne Carey, our speaker and fearless leader. Many of you have seen emails that she's written for the last 10 years, encouraging you to be at the Capitol for this or be at the Capitol for that. She made this happen, and all of us helped, but it doesn't happen without leadership. And we're so grateful that Corinne could be here today to tell us all the details about the final law that passed. So you know what right you and your loved ones and New Yorkers for generations will have. Thanks.
Thank you so much, Nancy. It's true, you need like a conductor, like any good choir does, but the music doesn't happen unless the people are singing, right? Really? I have to, how is that? A little bit better? So the music doesn't happen unless the people sing. You need the conductor. But you all, those of you who wrote letters, who came to the Capitol, who communicated with your lawmakers, this is your victory. You made this happen. And for years and years and years to come, you will know that you had a hand in making sure that people don't suffer unnecessarily at the end of life and have the autonomy that they deserve. So I am so pleased to be here today. The Unitarian, Universalist congregations across the state have been so essential to this work, and you all in Albany have been the backbone. I was reminiscing with Nancy about doing postcards in the basement years ago, and I joked that I had never been in the front door of the Unitarian Church before, so it was nice to come this morning and see you all. So I'm gonna present, oh, is this gonna be me all the time? Oh no, here we go. I'm going to talk about what the new law does with a caveat. There are regulations that will be promulgated. The law doesn't go into effect until August 5th. So there are some things that we don't know yet, and I'll answer questions along the way. I'll stop every once in a while and ask if there are questions, but here we go. Today, we will talk about what end-of-life options exist now in New York, what New York's Medical Aid in Dying Act will do, what's next, what do we have to look forward to, the resources that Compassionate Choices has to offer seriously ill people and their families, and instead of taking questions at the end, I'm probably just going to stop every once in a while and take questions. But there are some frequently asked questions at the end that if we haven't gotten to, I'll go over. Compassionate Choices is a national nonprofit organization that works to expand options and empower everyone to chart their own end-of-life journey. We've been most closely associated with medical aid in dying, but that's just one slice of the work that we do. We work in communities to help people understand how to do advanced care planning. We have an end-of-life consultation line where we've got specialists that can help families navigate the kind of care that they want at the end of their lives. We have a litigation project which helps people vindicate their rights in the courts when advance directives are not respected by healthcare professionals. We go to court. And we also do national programs on a whole host of end-of-life experience, a whole host of end-of-life resources like death doulas, for example, and various burial practices. So Compassionate Choices has a lot of resources. We'll go over some of those at the end of this, but I would encourage you to visit our website if you're interested in this topic. So what end-of-life options exist in New York now? When I talk to people about how they envision the end of their life, most people say that they want to die at home, near their loved ones, with their pain and discomfort managed, with their spiritual needs and values respected, feeling safe and comforted, and feeling peaceful. Some people describe wanting to be on a clean bed with a window open and the breeze blowing through, grandchildren all around, telling you how much you meant to them. But death doesn't always happen that way. In fact, it very rarely happens. It's a gift when that kind of ending is possible. And that's in part due to how we die. The kinds of diseases that people die from don't lend to that kind of a peaceful death. Different kinds of cancers, they now call it a death profile. What does death from ovarian cancer look like? What does death from pancreatic cancer look like? It's all a little bit different. But some of the worst deaths are from cancer. And the suffering is great. And oftentimes people find themselves in a hospital at the end and not at home, so that the pain can be managed. What options then exist for people to avoid that kind of suffering? Well, let's talk about what happens when you do get a terminal diagnosis. Every decisionally capable adult in this country has the right to seek all available medical treatment and interventions, limited only by your ability to pay, which is, as you know, no small limitation, which is why there are a lot of people fighting for the New York Health Act for universal health care here in New York. Concomitantly, people also have the right to discontinue or refuse treatment. The United States Supreme Court has affirmed the right of any decisionally capable adult to refuse or discontinue treatment. You can discontinue dialysis, you can discontinue chemotherapy whenever that suffering becomes too great for you to bear. When treatment is discontinued, people can often opt for palliative care. Palliative care is a developing field. It should be offered to everyone experiencing illness and a painful treatment regimen. You don't have to be terminally ill to access palliative care. Palliative care can be accessed by anyone of any age at any stage of illness. And really, palliative care focuses on relieving suffering, not curing, not reversing an illness, but simply relieving suffering. Hospice services are a subset of palliative care. Hospice, if you've heard that term, is not a place. It is a set of services offered in the place where someone resides. And hospice is delivered by an interdisciplinary team of healthcare professionals, social workers, spiritual advisors, and they provide services not only to the terminally ill person, but also to the family. And oftentimes, palliative care in conjunction with hospice care is enough to relieve the suffering that people experience at the end of life. But when it is not, and death becomes a drawn-out process where people are suffering without remediation, voluntarily stopping eating and drinking can be an option for people. It's not an easy option to access. Food is such an important part of our culture and our lives. I was just remarking about how every good celebration has to have a good sheet cake, and that happened here. But I remember when my own father was dying, it was around Thanksgiving, or it was around the holidays, and it was breaking our heart that he didn't want to eat Thanksgiving dinner. And I remember almost forcing him to have some mashed potatoes. And that is not what the body needs when it's shutting down and dying, but it's so counterintuitive to the way that we nurture and the way that we show love, that the idea of voluntarily stopping eating and drinking and have a family watch that process is very hard. And most of the time it can only be accomplished with significant medical support, and sometimes in an institutional setting. When voluntarily stopping eating and drinking is not a good option, or if it doesn't really work for the family, another option is called palliative sedation. And that, in layman's terms, is really about medicating someone to the point of unconsciousness and withholding nutrition and hydration until the body expires. Palliative sedation is not offered as such. It's not like you're presented with a menu of options and you get to check, like, I'd like palliative sedation. Often, as with a lot of healthcare, for those of you that have helped someone with a serious illness or at the end of life know, it requires advocacy. Advocacy from the patient, maybe, or from the family members, to get the doctors to grant this kind of care. So it's not something that will be suggested. It's something that you have to advocate for. And sometimes with palliative sedation, it's tricky. I'll get to the question right after this. If you give the person too much of the palliative sedation, what happens? The person dies. And if you give too little, the person wakes up in interminable pain. It's kind of more of an art than a science. And so it's tricky, and it doesn't always work for people. And that's why, that's one of the reasons why people have been pressing for the option of medical aid in dying, which puts a lot more control in the hands of the dying person than any of the other options. So I'll stop here and see if folks have questions. And I know we have one here. Yeah.
Is there a template of how long, if I were to choose at whatever my illness to do that? You know, if there,
I'll repeat the question. Yeah. Yeah. Yeah, the question is about what is the timeline for stopping eating and drinking? How long would it take for someone to die if they stopped eating and drinking? And it really is so dependent on the body and the illness. For some people, it could be 2 to 3 days. My mother stopped eating and drinking when she was on dialysis a few months ago, and they said it would be a matter of 2 to 3 days. She started eating again, and she's still with us today. But the prediction for her level of infirmity and her body and her weight and her what's the word, moisture level, what's that, hydration levels, those are really key. And so even giving someone a little bit of water will keep them alive for a lot longer. So 2 to 3 days for someone who's very frail at certain medical conditions, but it could be a week, 2 weeks for others. Some people have described sitting vigil at a bedside for weeks while someone passes away. And who knows, maybe water was given. It's very hard to resist doing that. So it could be a long, drawn-out process. All right. The other point I want to make about these options is that these are not either or choices. Someone can choose palliative care and hospice and voluntarily stopping eating and drinking. But there's one major exception, and that is that when you choose hospice, you have to forego curative care. And that is very hard for people because the line between what's curative and what's palliative is sometimes hard to discern. So there are some people who experience certain aspects of their illness who are not comfortable with not receiving certain types of care, and they have to drop off of hospice and then re-sign back up again. But for all of the other options, it's a both and, not an either or. So there was concern when we launched this campaign 10 years ago that it would be either medical aid in dying or hospice care. And hospice providers were like, wait a second, we're under-resourced, we're underutilized, and we do a lot of good for people and their families. And we had to continually make the point that people can be on hospice care and also choose the option of medical aid in dying. And in fact, over 86% of people do. In states that authorize medical aid in dying, I think I say this later, but most people are already enrolled in hospice care when they choose the option of medical aid in dying. So what is medical aid in dying? Medical aid in dying is a medical practice in which a mentally capable adult with a prognosis of 6 months less or less to live can request a prescription from their doctor that they can choose to self-ingest at a time of their choosing and on their own terms. And each of those elements is important, and you'll hear me repeat them a couple of times. It's a multi-step process with strict eligibility criteria, safeguards embedded in these laws ensure that anyone pursuing the option is protected, the providers, the family, the patient. Medical aid in dying is authorized now in, oh my gosh, what? 14 jurisdictions and 13 states. New York is the 13th state. The landscape is changing so quickly, I keep forgetting the talking point. Just this year, New York became the 13th state, but 2025 was really a banner year. The New York State Legislature, both chambers passed the bill, as well as did Delaware and Illinois, and their governors signed the bill by the end of the year. So this is the landscape that we're looking at. I actually ran the campaign to pass medical aid in dying in New Jersey, and that law passed in 2019, and I've been working with healthcare providers, families, and health systems in that state since then to monitor implementation. We've learned a lot from New Jersey, and that puts us in a very good position to avoid some of the pitfalls that we saw in New Jersey. Just a sense of how this is working in other states. About a quarter to a third of people who receive the prescription for medical aid in dying in the states that authorize it never take it. Their families describe this palliative effect of simply having the option on their loved one. Once someone has the option, has the prescription, either has picked it up or just simply knows that it's available from the pharmacy when they're ready for it, provides a kind of comfort that allows people to avoid kind of the mental suffering of knowing that when their suffering becomes too great, there's a door. People have described it as an exit, a door that they can open to relieve themselves of that pain. But oftentimes, because we love life and we want to continue to live, and people who actually want medical aid in dying are among the most full of life people I've ever met. They live life to the very last minute until it becomes unbearable. And so sometimes a lot of times, people die before they even use the prescription. As I mentioned, about 90% of the people who self-ingest medical aid in dying are already enrolled in hospice care when they use the prescription. And close to 80% of people who use medical aid in dying are actually able to die at home, which is really important because that aligns with what most Americans say their goals are. Just a brief history of medical aid in dying in New York. Prior to 2016, there were several bills that were carried by both Democrats and Republicans that were introduced in the state legislature. But in the spring of 2016, me and a bunch of other advocates sat down with the bill sponsors. We looked at the evidence from across the country. We looked at the bills that were pending here in New York, and we came up with New York's Medical Aid in Dying Act. It's been amended several times throughout the past decade, but as you see here in the spring, the bill was passed by both houses of the legislature. In the fall, the governor requested a number of amendments to the bill, and it took a while to negotiate with her the additional protections that she wanted to see. Those amendments were passed by the state legislature in early February, and then the bill was signed by the governor on February 6th. The law will take effect after a 6-month implementation period, during which the Department of Health will be writing regulations that will guide this practice. So the law will take effect on August 5th. We did so much work to make this happen together. As I mentioned, the bill was introduced. Do I have pictures on the slideshow? Yeah. So you'll see here, so many of the people that lined the hallways in Albany came from this congregation. We partnered with lawmakers. People came to the Capitol and shared their stories. The Medical Society reversed its longstanding opposition to the bill. We did precision lobbying in district. I don't know how many times this group met with Neil Breslin and Senator Pat Fahey over and over and over again. And one thing I had to keep reminding people is that when you're working on a campaign and you don't have the votes to pass something, every no vote is a potential yes vote. Because when something passes, it's because people have changed their minds. And leaving people the grace to work through their own processes, to overcome their own opposition, was key to this campaign. It's something that we, I think, should be very proud of, that we never demonized the people who were reluctant to sign on and support. And at the end of the day, we needed them. So here you see some shots from the state capitol. Congregations across the state, like the one on the bottom right, came together and wrote letters and postcards. And then these are scenes from when the governor announced that she would sign the bill and met with some of our terminally ill advocates. And then we went to the state capitol when the governor delivered her State of the State address and thanked lawmakers for their vote. I think it's important for us to remember that a lot of the people that fought for this right are no longer with us. And so I like to just take a moment and remember that we lost 30 people along the way. As this law was being debated in Albany. These are folks who went to the state capitol, walked the hallways, shared their stories, and most of them knew that this option would not exist for them, but they didn't want anyone to suffer the way that they had. And many of their family members were key members of our work throughout these 10 years. So what does New York's Medical Aid in Dying Act do? Eligibility criteria, as I mentioned, are strict in every state that has passed this kind of a law across the country, and that's no different here in New York. Those who are eligible are people who are adults, 18 years of age or older. They have to be state residents. They have to be terminally ill, and that means they have to have an illness that is incurable and irreversible. They also have to have a prognosis of 6 months or less to live, which is consistent with eligibility for hospice in most states. Actually, in New York, we're a little bit more enlightened, and we allow people to access hospice services when they have a year or less to live. They also have to be mentally capable of making informed medical decisions. And this is important because this means that you can't designate the choice of medical aid in dying in an advance directive for someday when you may be unable to make your own medical decisions. You can't say a healthcare proxy can make this decision for me. And that leads into the next one, which is that you have to be able to self-administer the medication. So no one can administer it to you. That's very different from laws in other countries. Every single law in the United States requires both mental capacity and also the ability to self-ingest the medication. I'm going to preempt a question that might be on some of your minds, and that is, what about people with neurodegenerative diseases that may not be able to self-ingest? And I will say that in our experience across the country, there are few conditions that prevent someone from self-ingesting if they're mentally capable. And that's because healthcare providers have come up with a whole host of ways to ensure that someone can self-administer something by taking the last decisional act. It does not mean that you have to hold a glass and drink something. It means that you just have to take that last act, whether that's indicating something with your eyes or pressing a button. You just have to be the one doing it at the end. No one can do it for you. But there will be some people that who will not be able to self-ingest, and that is the trade-off between the safeguards that lawmakers want to see and the autonomy that we all deserve. So I just want to acknowledge that right now, that was a trade-off. A lot of these things were trade-offs. So I'm going to stop and answer some questions. Yeah, so there was a lawsuit brought in both Oregon and Vermont stating that, yes? Oh, repeat the question, yes. What is the, that there was a thought that the residency requirements for medical aid in dying may have been overturned, and that is true in some courts. So in Oregon and Vermont, there was a lawsuit saying that residency restrictions for medical aid in dying were unconstitutional, and the states settled those lawsuits. And the legislature went back and removed the residency requirement from the law in Vermont and Oregon. In New Jersey, the courts rejected that challenge. And it was a very harsh decision that said that the state had the ability to restrict this kind of healthcare to state residents. It's interesting because even though there's been a lot of talk about restrictions around abortion laws, this is the only medical practice where the restriction is on the patient, that you can't access care. The restrictions on abortion care apply to providers delivering care to out-of-state residents, but they don't apply to patients. This is the only restriction for patients in terms of state residency. And so Compassion and Choices thought it was an easy win in the courts, not so in New Jersey. And Governor Hochul saw the opinion in New Jersey. The timing was such that it didn't help us. And the governor added a residency requirement after the state legislature passed a bill without any residency. So now we do have a residency requirement. It's a little unclear. The health department is going to put together regulations, and they will probably mirror the kind of rules that apply to Medicaid eligibility. So when someone comes into the state and tries to access Medicaid, there are rules about how to prove that you're a state resident. They will probably use that formulation for medical aid in dying. But those rules are under development now. And the question was, how long? How long do you have to be a resident? Mm-hmm. Mm-hmm.
But if he were to have a lawyer draw up a statement that he wanted to consider this as an option, even though he's not actually going to be able to do that, is it going to help him if he actually says something in writing that he wants to consider something that he would want to try to do?
No. No. He needs to make the decision at the time that he's ingesting the medication. No, but there is a lot of end-of-life care planning that we can all do right now, that if we lose capacity at the end of life will guide the way that our healthcare providers deliver care. So for example, I'll give you one example. I was giving a talk at the Humanist Society here in Albany a couple of years ago, and I was talking about this idea of adding a rider to your living will. It's called a dementia provision in some circles. And what it does is it tells your healthcare providers that should you be unable to make your own medical decisions because of a dementia or Alzheimer's diagnosis, that you no longer want curative treatment. And a woman in the audience said that her mother had done this. Her mother cared for her own mother with dementia and knew that she did not want to linger. And so she put an advance directive in place that she didn't want any curative treatment if she were to be diagnosed with dementia. Well, fast forward, the mother falls, common, breaks her hip, ends up in the hospital, develops a hospital-borne infection. And the doctor calls the mother in and calls the daughter in and says, your mother has this rider to her living will that says that she doesn't want any curative treatment. That means that we wouldn't administer antibiotics. And do you know what that means? And the daughter said, explain. And the doctor said she'll be gone within the week. And the daughter said it felt like she had been given a gift because she didn't have to make that decision for her mother. Her mother already made it. That's a decision we can all make now and put in place in our advance directives. So if he still has capacity, that is something that he should consider, because there are a number of treatments that are routinely administered to keep someone alive beyond the point that they want to be alive. Yeah, so there are alternatives. Any other questions about the eligibility? Yeah. Maybe. It's not easy to access VSED anyway. Accessing VSED once you've lost capacity is even harder, but having a very clear advance directive and a stalwart advocate could make that happen. Not easy. Oh, the question is, could you designate that you want to stop eating and drinking in an advance directive if you lose capacity? Can your healthcare proxy then help that process happen? It's very difficult, yes. Mm-hmm. Yeah. Mm-hmm. Can I get back to you on the second one? Because I'll lose the thread that already started in my mind. Okay. So the question was, there was some level of surprise that one of the requirements for eligibility isn't that you are suffering interminably or that you are experiencing pain, and contrasting that to Holland, where that is a requirement. It's a barrier to care in Holland, even though people think that Holland's law is very permissive. But you have to show that you've been suffering in Holland. And in Canada, you can access medical aid in dying even if you're not terminally ill. And in fact, mental health issues are a big concern there. And the numbers of people accessing medical aid in dying in Canada are concerning to many people. It's a large percentage. Laws in the United States are very similar to the first law that was ever passed in Oregon in 1994. And these eligibility criteria have never changed over a quarter of a century, and these have remained what lawmakers in this country find acceptable. So that's why we require that someone be dying actually, to access medical aid in dying, but we don't require that they demonstrate that they're suffering. And why is that? Because it's not just suffering that people ask for medical aid in dying for. It's not just pain, even though all of us, I'm sure, have experienced the end of someone's life where we've watched them suffer despite good palliative care, despite good hospice care. We've watched people experience pain that's not being relieved with existing care. But the other reason that people want medical aid in dying is they want to be able to choreograph their own end-of-life experience. They want the autonomy to be able to gather the people around who they love. How often is it that we're at a bedside of a loved one and we decide now's the time to go home and take a shower? Now's the time to go sleep in my own bed instead of sitting next to the loved one. What happens when you've got loved ones who live in California? How do they know when to be at the bedside? And this is a really foundational reason that people want medical aid in dying, because they want to know when it's going to be. They don't want the memorial service after they die, so they can't hear the good things that people are saying about them. They want to gather people around before that. And so that's a reason why lawmakers are okay with the idea that we're not going to force people to declare that it's suffering or that it's pain. Does that make sense? Mm-hmm. Yes. It's not injectable. The question is, I use the term ingest or self-ingest or self-administer a few times. And the question is, what's the medication? It's not a pill and it's not an injection. It's actually a compounded mix of medications that are only available through a compounding pharmacy that are mixed with liquid and then ingested through the gastrointestinal tract. And that can be done through a feeding tube or through drinking something, but that's the way that it's ingested. Yeah. Other questions about eligibility? Yeah.
I don't know if this is legal or not, so I'm not gonna give any names, but a relative recently died. It was a tumor in the heart, and they have the surgeon said no, but they administered morphine, increasing amount. Now, that probably precipitated termination.
You know, it's interesting, right? I mean, oh, sure. Yeah. And the question is, we probably are all aware of people who, at the end of their lives, received increasing doses of morphine and the person dies. And in some ways, if you think about it, it's like a cause and effect situation, right? And also, people think about hospice as a place to go to die. Some people are afraid to go to hospice because it's like, well, if I go to hospice, I'm going to die. We're all going to die. We're all going to die. And the idea of morphine is that, yes, you can increase the dose of morphine. The intent cannot be to end someone's life. Could it happen with increased doses of morphine? It can happen that someone's heart stops, that they stop breathing with increasing amounts of morphine. But as long as the provider did not intend to bring about death, it's okay. In fact, the Catholic Church is very against medical aid in dying, but they acknowledge that there's a double effect of morphine, that you can relieve pain and suffering with morphine, and it could also bring about death, but your primary motivation can't be to bring about death. And so, yes, it has happened for years. The flip side of that is that there are some people who become so resistant to morphine that it won't work. So a lot of the lawmakers would say to us, why do we need medical aid in dying when you can just keep upping the dose of morphine? It stops working for some people, especially people who are otherwise healthy or whose bodies are younger and stronger. You can administer a lot of morphine and the person will not die. And that's one of the reasons why medical aid in dying is so important. Yeah, you can be resistant. You can, undergo, cancer treatment for years and be on various doses of morphine and keep increasing it, and your body develops a resistance to it. Yeah. Yep. Yeah.
just want to point out that morphine has other beneficial effects. Both of my parents were getting morphine as they died, and it actually prolonged their life, not because it was taking away pain, but it allowed them to their systems get the blood flowing through their bodies,
Mm.
and it kept them from feeling like they were suffocating. And the same is for same thing goes for hospice. Both of my parents lived a lot longer because they were on hospice.
Mhm.
But I just had to speak up because I think that that information is not broadly known, and people assume that the hospice folks are basically gentle killers.
Yes, that's true. There's a lot of misperception of end of life care, and that's why these conversations are so important. One of the things that I learned after my father died, he died of cancer, and he was a Marine, and he fought valiantly against the disease, right? Underwent every treatment there was until the very end. And what I learned over these past 10 years is that sometimes when you stop fighting and you acknowledge that death is imminent, you can often live a lot longer with a better quality of life. Once you enter hospice, once you start receiving palliative care, I didn't know that about morphine, but that's an important thing to understand.
They could barely breathe. They
Yeah,
were gasping for breath. A little bit of morphine, and suddenly they didn't have that urge to
yeah,
breathe that way. And my dad was on it for 4 months or so.
wow,
My
yeah.
mother for over a month. And at the point that she went on hospice care, I didn't think she was going to make it through the night.
Mm. Yeah, it's amazing what happens when you can calm a system down, and live to the fullest until the very end. So, all right, let's move on. So, what does the process of seeking medical aid in dying require? I think some of this is going to be refined through the regulations, but at base, we know that someone will have to make one oral request to their attending physician. And the governor wanted to see that the person was truly acting voluntarily. So she required that they make a video or audio recording that will be appended to the medical file. So you have to make an oral request, and that has to be taped and stored in your medical record. Then there needs to be a written request witnessed by two people, neither of whom can have any interest in your estate. So not your family member, not your doctor, no one who stands to inherit from your estate. And if you've disowned your daughter and she's not receiving anything from your estate, she can't do it either. Like no one who's interested in the end of your life can be a witness. You have to have confirmation of both the terminal illness, the 6-month prognosis, and the mental capacity by someone who's called a consulting physician. And then you also have to be evaluated by either a psychiatrist, a psychologist, or a neurologist to make sure that you have the mental capacity to make this decision. And that's another safeguard that the governor added to this bill. Now, to be clear, both doctors, the attending and the consulting doctor, have to make the determination that you have mental capacity, and they make those determinations routinely when people are deciding whether to, undergo surgery, stop treatment, opt for, alternative treatments or experimental treatments. It's a routine thing that doctors do every time you go for care, is to assess your mental capacity to consent to certain types of care. But the governor wanted additional protections, and so now there has to be a separate mental health evaluation. She also wanted a waiting period between the time that the person has the attending physician write the prescription and when that medication can be dispensed. And that's a 5-day waiting period. And that waiting period can be waived if someone is expected to die during that period. So sometimes it takes a while to line all of these processes up. And, we didn't want to see people having to undergo an additional waiting period. So now there's a waiver of that waiting period. Additional provisions attached to the law are that there needs to be an in-person medical evaluation, and that in-person requirement can be waived if it will result in significant hardship for the patient. There are strict conflict of interest rules for witnesses and interpreters, so non-English speakers have protections in the law. There are criminal penalties for anyone who coerces someone into requesting medical aid in dying. Violations by healthcare providers or anyone else involved in the process are punishable both under the criminal law and through professional disciplinary proceedings. Religiously affiliated home hospice providers can opt out entirely, but they can't prevent people who are receiving their care from accessing medical aid in dying in their own home with other providers. And that was a really important carve out. The Department of Health will be getting reports from doctors of people who request medical aid in dying and who get a prescription. And then they'll deliver those reports to the legislature annually, and the reports will be available on their website. So that's how we know a lot about how medical aid in dying is playing out in other states, because the Department of Health de-identified. That's true. Yes, that's true. So confidentiality of patients is protected. Yes.
It seems like all of this might be quite expensive. There's one child psychologist that I know that works with people who are in institutions. Her concern is that the relatives of these people will be anxious to have them die sooner because their care is so expensive. So just putting that together, this seems like the kind of aid that helps people like us, as opposed to a whole different group of people who have much less control over their lives. So I'm just putting that forward. But the other thing is, does insurance cover any of these costs? Is insurance picking this up so that people who are destitute have the opportunity to consider this as well?
Yeah, Julie is bringing up a really important point about health equity. And will people who are uninsured maybe, or who have public health insurance, be able to access this care? Will those insurance companies pay? And there is a restriction at the federal level. So VA insurance, Medicaid, Medicare will not pay for any of this at all. But state Medicaid programs have stepped in several states to cover these costs. Many private insurance companies don't advertise that they cover the cost of medical aid in dying, but they do. So people have to proactively ask their insurance companies whether they will cover the cost. Oftentimes, the consultations that are done with providers are covered by health insurance, but the medication is not. And the medication can cost between $500 and $900. Now, putting it in perspective, it's the last medication that someone will need. There are grant programs available from some nonprofit organizations in various states to pay for that care. And let's not forget, we have a broken healthcare system. So how many times have we seen a GoFundMe for cancer care? So people will be doing that for this as well. But it's a very good question. Yeah.
People who have nobody.
Yes.
Who have nobody.
That's true.
Relatives, they all died or whatever. Is there any plan, or is there any way in which that this information gets to those people who might just never hear about this?
I think this is a really good question. I think it's a two-part question, really. I think what you're concerned about people who have no one, whose loved ones may have predeceased them, whose friends may have died. And oftentimes when we think about end-of-life planning, we talk about planning with your loved ones and what happens when there are no loved ones left. So I do a whole presentation about how to create circles of care, circles of advocates, self-advocates, by request. If someone, if someone wanted that presentation, we would give it. Yeah. Yeah. Oh, we've gone into nursing homes as well. I mean, they often don't like that because they don't want to focus on death and dying, but to the extent that we go, we do. But I think it's important, this idea of how are you aware of this option? And I will say that health literacy is the biggest indicator of people being able to access this option. It's not really about being wealthy. It's not entirely about race, although this is, I mean, the statistics show that the majority of people who use medical aid in dying are people with advanced degrees. They are mostly white and they are well-resourced, right? So why is that? There are confounding factors. There are cultural factors, but there are also awareness issues. And in order to access many types of care in our healthcare system, you have to be health literate. So how do you promote health literacy and people understanding what their options are? It's doing outreach. It's doing outreach. So I'm here today, and I know the kind of crowd that we've got here. You all are aware of healthcare issues, but many people are not. And so getting access to those audiences is really important. Yeah. Yes. Yeah, the speaker was just mentioning that New York State has an ombudsman program for long-term care, and that's true. Yes, and Nancy, can we go over a few minutes or no? Yeah, okay, yeah. A few more questions and then we'll move on, yeah. Lots of data, yeah, yeah. Yeah, so the question is, do we know how many people are using medical aid and dying in other states? And Compassion and Choices, my organization, publishes a utilization report every year that shows the number of people who use medical aid and dying. In states that just authorize, there will be just a handful. The first year in New York, there won't be that many. But the number really plateaus at under 1% of all people who die. So in Oregon, it's under 1% of people who die use medical aid in dying. And that's generally what we see across the country. Was there another, you had another question. Mm-hmm.
I think it's a lot easier for those of us in the audience to understand the question. I have a good friend whose husband died in November, and we've discussed the medical aid in dying quite a bit, and she has expressed concern about the contingency for having psychological appreciation of a person's mental state. And she said in those last 6 months, when he was on hospice, that there would be days when he would be very, very, coherent. And there would be other days when he would be, perhaps because of medication, I don't know, less so. And so my question is, does it make sense for a person like me, who has no relationship with a psychologist, to create a relationship beforehand rather than wait till you are asking for this?
I love that question. The question is, does it make sense to cultivate a relationship with a psychologist before? You embed your question in another question about capacity, but I want to address it more largely. It is true that the law requires that you be mentally capable in order to access this. There's no exception to that. You will notice, however, that there is no continuing assessment of capacity. Once you are assessed as being capable, after you make the oral request and the written request, you are able to use medical aid in dying. There will be days, we all know this, where you will be a little less capable than you were another day due to the medication, the illness. There's no ongoing capacity assessment. Once you've made the decision and you've been assessed, you have that right. The bigger question is, should you develop a relationship with a psychologist beforehand? And the answer is yes, for all of us. None of us know what is around the corner. And we need to know now, today, whether the healthcare providers that are giving us care are going to respect our values and our wishes. So even if you're never thinking about medical aid in dying, even if you have no illnesses at all, you should be talking to your doctor and finding out whether there are any problems with respecting your wishes, whatever those wishes are. If you are receiving care at Albany Med and your providers are within that system, have the conversation. You'll learn a lot about what they will do and what they won't do. If you're receiving care at St. Peter's, you ought to go have that conversation now because there are a lot of things that you may face at the end of life that your provider will not deliver. Not just at the end of life either. There are religious refusals for a lot of different kinds of healthcare. I can't remember how many, they're called ethical directives. I give a whole talk on ERDs, ethical religious directives in healthcare systems, ways that healthcare providers can say that is a violation of our ethics and we won't provide that care. You should know that. And there was a bill pending in the New York State Legislature called the Hospital Transparency Act that would have required hospitals to tell the Department of Health what kinds of care they would provide and not. And it did not pass, and it has not been signed by the governor. So that's on us. We have to have those conversations now. Yeah.
I'm glad you brought that up because that was going to be my question. Strange experience of going for a colonoscopy at a St. Peter's affiliated GI office, and they sent me a patient handbook, and I read it. And there's a provision in there that says your care at St. Peter's is governed by the bishop's rules.
Yep.
And
Yes, they are.
they are free to ignore advance directives.
Yes, they are.
By having and by having the procedure, I'm giving my consent and my understanding that that's the case.
You are absolutely right. The bishops have the ability to control the kind of care that we get in Catholic healthcare institutions. And there are more and more Catholic healthcare institutions. They're the largest healthcare provider in this country. So it's very important for people to have those conversations with their providers. Fred, did you? Yeah.
I just wanted to know, since we're on this topic, if you haven't seen it already over there on the stage next to Corinne, Compassion Choices has developed a really lovely guide that can help you get started having this conversation with your providers. We give you some scripting language and human scripting language, and we have a whole host of other tools available online, but very specifically before you leave today, and prep for starting to having those conversations with your providers, I recommend you stop by that handout station up there and grab that.
I have a feeling we're not going to be able to make it through all of the slides. So I'm just going to zip through quickly and show you what's here, and then I can make this available to people. Yeah. Yes.
Do you need to have a relationship with the psychologist or psychiatrist? And you don't.
No, you don't have to have a pre-existing relationship with the psychiatrist.
As like Choices New York, and they're developing a whole database of physicians and pharmacists who are interested in participating in this in one way or another, and that will lead to a list of psychologists and psychiatrists who will participate. So you don't have to have a relationship. Your doctor will have a website to look online and find somebody who's interested. And
Thank you, Mary. That's really important to note. Yes.
Since that list will be statewide, Corinne and her colleagues want to have that be a telehealth visit, so you don't have to travel.
Yeah. Yeah. Yeah, that is true. Yeah. Yeah.
for the religious affiliated hospitals.
Mhm.
Is there anything in the bill that requires them to advise patients that they have other options?
I mean, there is. Will they do it is another question. And the question is there a provision in the bill that requires the provider to refer you or let you know what your options are? There's a law called the EMTALA. No. But that's a federal provision, EMTALA. But there's a state law that requires physicians to let a terminally ill person know about all of their options. I don't know how that's going to play out with religiously affiliated healthcare providers. Officially, there's a rule that requires that. I don't know how it's going to play out. I don't have a good answer for you. Yeah. Yes. Mm. Yeah, I think we will see that. Yeah, we will see that. All right. Yes. Question. It is in a number of ways. In every state that has passed a medical aid in dying law, there has been a legal challenge. So this law will be challenged in court, I can almost guarantee you, and we will win. We're ready for it at Compassion and Choices. We have a litigation department that's already gearing up to defend the law, and I know that the New York State Bar Association is very focused on this as well. So it's not just challenging the law, it's also what's going to happen when there are impermissible refusals. And really the law gives quite a bit of discretion to doctors to say, I'm not comfortable practicing. So there will be a lot of doctors, most doctors, who won't, at least in the first few years, be willing to deliver this care. And that's why the database that Mary mentioned is going to be so important. But I do think that there are lawyers that are gearing up, not only at Compassion and Choices, but also the Bar Association. I know that we've spoken to a number of elder law attorneys across the state. So yeah, I think that people are getting ready for this. Yeah. We need that Hospital Transparency Act, though, that's for sure, because we all need to know when our care is going to be dictated by the bishops. Let me show you what else is in here, because maybe what we'll do is make it available to people, and I'm always available for questions afterwards as well. But the mental health evaluation, it's really important to understand that this is not a capacity determination like going to court for a guardianship, for example. This is just about determining whether someone can understand their options, weigh the benefits and the risks, make an informed decision, and communicate that choice to their doctor. That's all the psychiatrist and the psychologist are charged with determining under the law. The medications, I think I mentioned before, there's no required or standard prescription. Doctors use their judgment about what a person will need. The route of self-administration is determined by the doctor. The mixture of medication is determined by the doctor. There's a medication that relieves nausea and anxiety, and then another medication that slows breathing and stops the heart. It's, as I said, prepared by a compounding pharmacy, and I already know that Fallon Wellness Pharmacy is completely on board. If those of you who are aware of them, fantastic family-run pharmacy, and they'll be a prescriber in this area. And then it's dispensed, as I said, as a powder. Protections for patients and providers, I referenced this before. As long as you're complying with all aspects of the law, you have immunity under the law. And I'm just going to end with what you can do. You can sign up on our mailing list over here, and then I'll take some more questions to find out more about implementation, about how the Department of Health regs are written. There will be a public comment period, and we'll let folks know what the Department of Health comes up with and whether we need to be sending in comments to encourage them to change what they've decided. Although I have a lot of faith in our Department of Health. They're doing a great job, right, Mary?
The health commissioner is a longtime friend of mine. He has said he told his team, don't do anything to slow this down.
Yeah.
Slow things down to a grinding halt. He said none of that, and he's very supportive of the law. So I have great confidence that
I do too.
we'll be in good shape.
Jim McDonald is our Department of Health Commissioner, and he just happens to be the brother of John McDonald, who is my assembly member. Co-host. Yeah. Mm-hmm. Not a compounding pharmacy, though. It's not a compounding pharmacy, though. No. Yeah. Oh, let's talk afterwards. That's great. If you have ideas for other public education opportunities, like we talked about here, how do you get the word out? Let me know. We can work together to put something together. You can join a patients group at your own healthcare institution and encourage them to develop policies that are supportive of medical aid in dying. And you can become a volunteer, like some of you in the room are, and learn more about how you can share this information about this new right in your own community. And I am going to just leave you with these resources that are all available on our website. We've got an end-of-life guide and toolkit. We've got a policy book that talks about medical aid in dying. As I mentioned, a utilization report where you can see how this is playing out in other states. We have guidance for clinicians. We have a 1-800 number for family members and seriously ill people to consult with an end-of-life care professional to help you navigate the kind of care that you might need. We have a website where all of these materials are located, and as the Department of Health finishes their regulations, we'll have a specific booklet for New York and how this law is going to play out given the rules that they adopt. So with that, I will leave it here with my email address. I should have put Fran's on there too, but she's got business cards. So if you need to reach us, reach out that way. Any final questions before we wrap up? Mm-hmm.
That accumulates funds for people who can't afford to do this, but because they can just tap into?
In other states, there are organizations that solicit donations to help people who can't afford this care. I have not seen that arise yet in New York. It may be that End of Life Choices New York decides to do that. Other groups like that in other states have, but I don't know yet. Would help?
Contribute to something that people could dip into if they just can't afford it.
Yes, we will certainly let you know. All right. Any other questions?
Maybe offer, if anybody has any other questions, well, Nancy and I have been really involved in this and looking for our chair. And so we would be happy to answer questions at any point. I'm on the implementation, two of the implementation committees, one about education and one of broader one. So I'm more in touch with day-to-day stuff, what's going on there. And that group is working with California called the Academy of Aid in Dying Medicine that has worked with about 10 other states on their implementation. So they are a font of wisdom about all of these things. They have 7 or 8 online modules, first of which is intended for the general public as well as healthcare providers who just want an introduction, much as we've heard today. And then there are specific ones about for pharmacists and primary care docs, psychologists, psychiatrists, about providing those brief mental health evaluations. So it is a very thoroughly worked out set, and they have tweaked their materials. They are amazing. We think we need this, and a week later, done. And they've tweaked all of their information to match the New York State specifics of the law. So they're really an amazing resource. We're on it, and it'll happen.
Thank you, Mary. And thank you, Nancy, for inviting me here, your whole committee. I love coming to the Albany UU. Thank you.
I have a PDF copy of this presentation, which I'll send out to the End of Life Choice group if you're on that list. And if you're not on it and you're a member of this church, I can add you to it. If you're not a member, give me your email address on a piece of paper. Oh, did you all sign in at the front? If you're okay, then I have your email address. Okay. Oh, great. Anybody needs to sign? Thank you so much. Thanks, Corinne.